we have, along with Dean Carol Rogers of the Faculty of Health Sciences, we've put together a lunchtime virtual panel, which is covering some of the most concerning issues that involve the crossover between social science and humanities and health science today. We began last month with a panel on climate change and human health, which some of you might have attended, which went very well. We wanted to continue it with a discussion of what is arguably one of the greatest public health threats that we face today, which is the opioid crisis. I'll begin very quickly by acknowledging the lands and people of the Mississaugas of Scugog Island First Nations. Ontario Tech is situated on the traditional territory of the Mississaugas. Although I'm coming to you today myself, I'm outside of Montreal, which is near Conalacque, which on the St. Lawrence River, which is Mohawk territory as well. So I'd like to acknowledge the indigenous lands from which we speak. So what I'd like to do then, very briefly, is ask our panelists to introduce themselves to you. But we do have a panel, I think, of just fantastic background and solutions-oriented thinking people. So I think that's very exciting because the focus here really is on solutions. We know how bad this pandemic is. I'm going to use the term pandemic. I realize that can be controversial, but I'll jump out there. There are 19 to 20 deaths per day across Canada from opioid overdoses. That figure fluctuates. It goes up or down. In 2020 in Durham region alone, many of you are probably in Durham region, there were 94 deaths, 5 times the number that there were in 2013. So there's no question, you know, that that the COVID pandemic has exacerbated as well, right? This impact. That's another thing that we might get to discuss today. We have with us today, I won't say doctor because they're all doctors, right? They're all PhDs, one way or the other. So just assume I'm applying it. We have Winnie Sun, who is an assistant professor and registered nurse at Ontario Tech University. Sheila Jennings, who is a lecturer in the Faculty of Social Science and Humanities at Ontario Tech University. Julian Kola, who is at the Canadian Institute for Substance Use Research at the University of Victoria. Sahida Afridi, who is division head of addiction medicine at Lake Ridge Health. Serene Kirpen, who is assistant professor at Ontario Tech University in the Faculty of Health Sciences, and Beth Brander, who is the senior director of mental health and addictions at Lake Ridge Health. So this is quite a lineup. We're very fortunate to have them all here today and to hear different opinions and advice coming from them, policy advice included. So could we please just make a quick round table with self-introductions, and we'll just use the order that I just covered, and we'll begin with Dr. Sun.
Hello, everyone. I'm Dr. Winnie Sun, Assistant Professor at the Faculty of Health Sciences at Ontario Tech University. I'm also having a research appointment as a co-research director for the Advancement in Dementia Care Center in Ontario Shore Centre for Mental Health Sciences. And my program of research focuses on gerontology, community health, with research expertise related to mental health of the older adults, including the opioid crisis. I'm currently leading a City Studio Durham initiative to explore the needs of the homeless population in the community hubs, focusing on the impact of early onset aging and opioid crisis, and equitable access to naloxone.
Thank you, Dr. Sun. Dr. Jennings.
Hi, everyone. Thanks for having me on this amazing panel this afternoon. So I'm here in a variety of capacities. I lecture, I'm teaching a number of courses this semester at Ontario Tech. I also have practiced in the area of family and child welfare law, and I have acted for mothers who use substances in the past in relation to challenges taking their children away. And I'm also, on the flip side of that, a mother of a young adult who has had numerous overdoses across provinces. And I advocate for him, but I also advocate for the children of anybody who's listening through an organization called Mom Stop the Harm, which is a national network of Canadian families. Families of choice join as well, not just biological family, to help provide support, but also with the aims that we have, which I can talk about a little bit later. My son has lost, I think it's 23 out of his circle. The most recent person who passed was his very close friend, Davin, who passed away on January the 15th. And that was a particularly devastating loss. Yeah, I'll leave it at that because I'm sure I'll have other comments later. Thanks.
Okay, thank you. Dr. Kola.
Thanks, Peter. So my name is Jillian Kola. I'm currently a postdoctoral fellow at the Canadian Institute for Substance Use Research at the University of Victoria. I'm located in Toronto, where I also have an appointment as a postdoctoral fellow at the Centre for Drug Policy Evaluation at St. Michael's Hospital. I use qualitative methods and ethnography within my public health research program to look at how we can best deliver health and social services to people who are experiencing different forms of vulnerability. And in the last 5 years, this has really narrowed down to look at people who use drugs and particularly people who are experiencing homelessness. So a lot of my work in the last 5 years has unfortunately been around documenting the crisis of overdose deaths that we've been experiencing here in Ontario and looking at the factors that contribute to overdose deaths. I've also been doing some work examining the impacts of overdose-related loss, both on frontline harm reduction workers, as well as on communities of people who use drugs. As Sheila very unfortunately just illustrated, people who use drugs have suffered tremendous losses within their communities. And so some of my research is looking at how we might be able to support them in this enormous amount of loss that they're facing. The next element of my research program is to examine options to respond to the overdose crisis. And so I ask a lot of questions around what's the ideal continuum of care and services that we can put in place within the health and social services system to address the overdose crisis. I'm very happy to speak a bit more about that during the panel today. Thank you.
Okay, thank you, Jillian. Dr. Afridi?
Yeah. Thank you for inviting me. So I'm a public health preventive medicine as well as addiction medicine specialist. After graduating from University of Ottawa, I have worked in Alberta and I was covering the whole South Zone, including Blood Tribe, Siksika Tribe. So I have served those nations as well. Also covered the inner city population for Edmonton. During the pandemic, I moved to Ontario to take care of my parents and got the opportunity to work with Lake Ridge Health, Oshawa. So I've been serving here. And again, I think after Vancouver, Edmonton, I have seen, escalating rates of opioid overdoses as well as alcohol too within the Oshawa Durham region as well, I must say. So, and I have worked across all the 5 hospitals of Lake Ridge Health, detox and rapid access addiction medicine clinics.
Okay, thank you very much. Dr. Kirpan.
Hi, good afternoon. So as you heard, I'm an assistant professor at Ontario Tech in Health Sciences, and I'm also an affiliate scientist at ICES here in Ontario. I do a lot of work with First Nation communities and Indigenous communities across Canada, and particularly focused on child health. And right now, what we're focused on is prenatal opioid exposure. So in Canada, many people and globally who use opioids are in their childbearing years. And here in Ontario, 1 in 20 babies are born to a mother who has used opioids. So they have been exposed in utero. Now that number is going down, and I might talk about that a little later, should the opportunity arise, and we're hopeful about that. But right now we're partnered with 13 First Nation communities across Ontario to help them access their own data to look at the incident rates within their community. But then we also have a qualitative arm to our project where we are working with mothers with lived experience. We are working with service providers, educators who sometimes are in a teaching or caregiver capacity for children who may have difficulties due to exposure, elders, anybody in communities who has invested interest, to look at the impacts, particularly in an Indigenous context, but then also see what the strengths are in their communities that are currently being used to address the crisis, because there are strengths that are being well used. But then also looking at what strategies communities want to move forward with to further mitigate the harm done due to opioid use during pregnancy. So we're just wrapping up findings on that project and should be reporting actually starting in the next month. And then from there, we hope to work with communities and further partners so that they have the resources to take those strategies and the data to advocate for themselves to further address the crisis. Thank you.
Thank you, Serene. And finally, Beth Brander, Master of Nursing Science, I think. Yes.
That's right.
Yeah.
Thank you. Hi, everyone. Good afternoon. Wow, what an amazing panel to be a part of today. And so happy to be here with all of you. So I'm Beth Brannan. I'm the Senior Director for Mental Health and Addictions here at Lakeridge Health. I have been working in the field of mental health and addictions for close to 35 years now. Most of my time has been spent at Ontario Shores Centre for Mental Health Sciences. And have played a variety of roles, you know, as a nurse, as an administrator, and I'm so proud now to be working with Lakeridge Health and really getting to see a different side of what that system looks like, really learning more about, particularly around addictions through our Pinewood Center, as well as we now have DMHS, or Durham Mental Health Service, that is also a part of the mental health and addictions family. So it gives us a really wonderful and unique opportunity to pull together kind of many of the social determinants of health together with our partners into kind of one approach in one system. So really happy to be here with you today. Hi.
Okay, thank you very much, Beth, and thanks to all our panelists. I wanted to mention if those in the audience, if you have a question, there's a chat function which is on the lower right of your screen. If you haven't used Google Meets before, it's the second out from the edge. It says chat with everyone when you hover your mouse over it or your cursor over it. And so feel free to add something there if you'd like to ask a specific question. I've got some questions we begin to discuss, but certainly would like some audience input. But we will limit that for now, at least, to the chat function, given the size of the audience today. And you know, let me just start with a basic question, I guess, that always sort of nags at me. And going back to a lot of things that have already been said, including Sheila's mention of personal experience and proximity. You know, I think we're probably at a point now where there are very few people that don't have some proximity to someone, right, who has suffered an overdose due to fentanyl or some other situation. And yet it doesn't seem to get the coverage, right? It still doesn't seem to be out there in the public imagination the way, obviously, you know, COVID was or what have you. So maybe someone would like to address that, and I'll just ask the panel members to use the raise hand function so I can identify who wants to speak. But you know, why is the opioid pandemic receiving less attention than it so obviously deserves? Sheila, maybe if you could start. Thank you.
Okay. I guess I'd take my hand down now. Yeah, I thought a lot about this enormous question, and I went in the direction of reasons not. First, it's not because of lack of advocacy. It's not because of the fact that it's claimed to be too complex to get at. We've heard that many, many times. It's not complex. Social problems are interacting, and that can make challenges, but it's not complex to simply decriminalize, provide safe supply, and then start taking steps in other directions as well once we have established that everyone can be here, can stay alive. Before the panel started, I went and took a peek at the Health Canada Twitter site till I was looking for something, a very simple thing, which had to do with the Health Canada's approval of diacetylmorphine hydrochloride, so heroin for people who are severely addicted, as they say. And I did find it, but I found it buried in scroll after scroll after scroll of tweets on all kinds of other things. There was just February 17th, this one tweet. And I think that's significant. I think there is less focus on it. And I think somehow, and the pandemic has a lot to do with it, but in 2019, I was one of, I believe we were 5 from Mom Stop the Harm who attended at the Federal Opioid Symposium here in Toronto, 2019. And a lot of cabinet ministers were there. Mayors were there. Vancouver Mayor Tory was there. And we had felt great promise with this symposium. But we cried. A lot of us cried, and some of us screamed and shouted in public at that symposium. Because we really felt that there was a lot of attention, but that there wasn't actually going to be any activity to follow through with that. So it just seemed like this glamorous event, but we didn't get a sense of buy-in at that time. So.
Yeah, thanks. Jillian?
Thanks, Peter. I think that when we think about why the overdose crisis, and I use the term overdose crisis very, very deliberately, because I like to distinguish the overdose crisis from an opioid crisis or an opioid pandemic, because right now I think that we're facing a crisis of overdose-related deaths that's driven primarily by a volatile and unpredictable street drug supply that's primarily composed of fentanyl. And this is unregulated fentanyl that has supplanted the drug supply in Southern Ontario over the last 5 years. I was doing my PhD dissertation research actually in 2016, when the street drug supply was still primarily heroin. And you would occasionally come across an overdose. You would occasionally have to intervene. I tend to spend a lot of time in the spaces in community where people gather to use drugs. And you would occasionally respond to an overdose, but it was a fairly infrequent occurrence. And in 2016, we had 867 people die of opioid overdoses in Ontario, which is a very large amount nonetheless. But then since 2016, fentanyl has come into the drug supply. And right now, pretty much all that you can find on the streets of Ontario is fentanyl. That is what people are selling. That is what people, for the most part, know that they are buying. And I think that we have to focus in on this if we're going to actually talk about the solutions that are going to make the most sense and be the most effective in addressing the current crisis that we're facing. Last year in Ontario in 2020, we're very slow with our data, so we haven't got 2021 data yet, but in 2020 in Ontario, we had 2,500 people die of opioid-related overdose. We've seen a massive increase, not just in Ontario, but across Canada. And this is due both to fentanyl in our drug supply, but also to our failed drug policies. I think one of the big issues that we need to face when we're trying to address this crisis is the fact that stigma towards people who use drugs and towards illicit drug use still drives the majority of our responses. We tend to tell people to pull themselves up by their bootstraps and just stop doing drugs. And unfortunately, what that's led to is thousands and thousands of people dead in Canada, 20,000, 25,000 alone in the last 5 years. It's not working. And we have evidence-based solutions, evidence-based interventions that we could be putting in place. But unfortunately, because we're still caught in this war on drugs prohibitionist mentality, we're very, very hesitant to put these solutions and interventions into place to try to address the root causes of the overdose crisis. And hopefully we can talk a little bit more about that later. I'll stop talking now so that some of my colleagues can say a few words as well.
Yeah, thanks, Jillian. Sahida?
Okay, thank you. I agree. Stigma has been the #1 cause for the worsening of this crisis, because unfortunately, addiction or substance use disorder have been perceived as a moral failure. It's not looked as a health issue, but a social issue, like it's a flaw of your character. And it doesn't get the attention of public as well as the policymaker, and we do not get the same response which we contribute towards any other communicable disease, hepatitis C or COVID-19, all hands on deck approach. But for opioid overdoses deaths, like if we compare it with the other communicable disease, we didn't get that much response, even though we have lost 24,622 Canadians from January 2016 till June 2021. And overall in North America, if you look, 600,000 North Americans have died because of this. The other thing I want to mention, another reason that we have singled out opioid prescribing as a causative agent or vector for the worsening of this crisis. And again, it's entangled with other major problem, which is chronic pain management, right? However, we have totally ignored the underlying main drivers of this problem, which is the structural determinants and social determinants of health. For example, even let's quickly talk about Oshawa, like lack of economic opportunities, right? Substandard housing condition, poor living condition, health inequities, and then social isolation, hopelessness, more traumas, early childhood, tough experiences, all those factors, they have never been integrated as the more driving factor for these crises. So I think those are some of the factors which taken into consideration to find the solutions.
Thank you. Beth.
Yeah, I just wanted to touch a little bit on something that Jillian had mentioned around stigma, and Dr. Afridi mentioned it as well. And, you know, I think the stigma both is twofold for these folks. You know, I think there's a lot of stigma that individuals hold themselves in saying, I need help, I have a challenge, I have a problem, that makes it very, very challenging to access care, to access resources. So I think there's a piece that plays into that. But I think the more curious piece to me is, you know, the stigma that, you know, we all hold in terms of individuals who engage in any kind of substance use. You know, I think it challenges us to say, you know, what assumptions do I bring to the table when I have this kind of a conversation? What are the biases that I bring to a conversation? And I think those are really important to truly pause and consider. And I say this because I think there is an incredible otherness to addictions. Everybody thinks, you know, yeah, it doesn't happen in my family, it doesn't happen to my friends, but it truly does. And I think, you know, I was so glad to hear you say that many of us are being touched by this crisis now in a different way. And I would hope that we can give some consideration to the fact that, you know, this is not a choice that people make to decide this is how I want to live. You know, it's something that evolves over time, you know, and this crisis is touching people of all walks of life. You know, we know that fentanyl now is, you know, touching all kinds of different substances outside of just, you know, the people who we typically think are using substances. You know, we're seeing it in party drugs. We're seeing it across the board. We're seeing folks come into our emergency departments of all ages, all walks. And I would just want to really challenge us when we're thinking about stigma to really think of that otherness and understand the impact that that has, you know, when we talk about accessing care, accessing services, creating safe conversations. I'll stop there.
Yeah, thank you. And I'm not going to start picking on the media. I think that there has been a lot of coverage of this in the media. It's been select, right? But it certainly hasn't been as widespread as I would expect. When you talk about figures like 25,000 deaths in the last 5 years, right? I mean, this should be on the front page almost every day, shouldn't it? And maybe that stigma's got something to do with that. Sorry, Dr. Kirpin, you raised your hand as well.
Yeah, thank you. Building off what others have said so far, I think that another concern of why we're seeing less attention in specifically to First Nation communities And I'll start this with saying that there is a high level of diversity in perspective. So with all the communities we work with, somebody might say, no, we don't want this in the media. And others are saying, put it on the front page every damn day. And even within a community, you might have one member of council say one thing and one say, no, we're not there yet in our journey. So I think, though, what we do hear from some communities is that they are vulnerable to misrepresentation in the media. It's another situation where they are the scapegoat for another complex issue around substance use in Canada. And there's that high level of stigmatization in the media. And then you layer on being an Indigenous community, and some communities don't want the attention brought to the issue. And then I'll put on my hat as somebody who's thinking about prenatal care and children, in that, you know, I appreciate that Sheila said it's not complex, but when you bring children in a situation, it's always more complex. And then you layer on remote and rural medicine issues, access to treatment. And then you layer on top of that an issue of intergenerational trauma, which is often the driving force behind addiction in communities. It can be very overwhelming, and where do communities start? So while we do have solutions, it becomes very layered when we bring in a First Nations perspective and a prenatal exposure perspective as well.
Yeah, clearly. Thank you. Sheila, you raised your hand again.
Yeah, I just wanted to sort of bounce off Serene's comments there. Yeah, I appreciate there are deep complexities to social problems that we have, or problems that get labeled as social. I also agree that it's very difficult sometimes for people to have their voices heard, and I would say particularly the voices of people who use drugs. So, for example, Marcus Gee of the Globe and Mail has approached me several times to ask to speak to my son. Well, why would my son, who's 31, who's a bicycle mechanic, why would he want to go in Globe and Mail? It's not good for business. And he's a super nice guy. Both of them are nice guys. Marcus came out to some of our meetings at various points. Yeah. And it might sell newspapers. I don't know if it would or not. But there is that voice that is very much ghettoized, I feel anyway. But you know, anyway, I'll leave it at that. It's just such a huge topic to talk about.
Yeah, of course. Yeah, Dr. Sun.
I just want to add on to what the panelists already talked about the stigma. That's definitely a huge problem. And the other thing about the reason why it's underrated in terms of the opioid crisis is that a lot of these are really about that public health issues and that social problems that it has been resolved. So we know that racialized group, they are the ones who frequently experience opioid-related deaths within their communities. Those are high concentration of people who are recent immigrants and in the neighborhood who are very racialized, and also with high material deprivation, such as lower income, poor quality of housing, lower education, higher likelihood of single parent families. And the other thing that we have to look into is also the homelessness. There is a high proportion of opioid-related deaths among people experiencing homelessness, significantly over the pandemic, especially, which is the work that I'm doing right now with homeless populations in the community hub. So there is this opioid crisis is really bigger than just the opioid crisis. There are public health issues involved. There's also the social problems that's involved as well.
Yeah, absolutely. And then I can see how it could be difficult to isolate this problem, or maybe even counterproductive too, right? In that context. Sahida?
Thank you. Just one last point I want to add towards stigma. We all spoke about the stigma from the societal perspective, but again, stigma from the frontline workers, from the physicians. That is a huge barrier for many people even to access treatment. Like instead of providing a compassionate, trauma-informed care, if you are rude, like your words heal and your words hurt. So really many people get disappointed, like even if they get the courage to present to emergency department or with the primary care physician who is not comfortable even talking about addiction, right? Forget about referring the patient to the nearest RAM clinic or appropriate setting. So that has been a huge barrier, and we definitely need to work on solution on that too. Training of our frontline healthcare provider, social services provider, our correctional services provider to have this non-stigmatized and compassionate use of the language.
Okay, absolutely. We're already heading towards solutions. I love it. Jillian, you raised your hand.
I just wanted to jump in on that because I think it's a very important and underappreciated point. I was part of a team that released a report just last month with the Ontario Drug Policy Research Network, where we actually looked at healthcare systems interactions among people who died of an opioid-related overdose during the pandemic. And we often have this idea that people who are dying of opioid-related overdoses are disconnected from the healthcare system. And that's frequently true. But what we found in our report was that 25% of all people who died of an opioid-related overdose during the first year of the pandemic had been seen in the healthcare system in the week before death. And 50% of people had been seen in the healthcare system in the month before death. So I think we have to recognize, and really as healthcare workers, social service workers, people who are on the front lines, I think we do have to spend some time reckoning with the fact that it's not a question of people not accessing the healthcare system. They frequently actually are trying to access the healthcare system. And from my qualitative research with people who use drugs, unfortunately, what they often find is a lot of stigma and judgment from healthcare providers across the board. And so I think that we really, really need to focus on how not only can we train people better, but also I don't think necessarily that our formal institutions of the healthcare system, like hospitals, are the best place to actually anchor the response to the overdose crisis. I think we have to move out into community as well, see what communities are working on, see how we can support communities and community-led initiatives, but also we do need to listen and trust the voices of people who use drugs, because they've actually very frequently been telling us what interventions would help them. They've been telling us about their experiences of stigma and discrimination, and we frequently don't act on that. And so I think we really, really need to move towards listening more carefully and trying to be better about implementing the solutions that are often right there in front of us.
Thanks, Jillian. Yeah, and arguably, you know, if we're dealing with this at the hospital level, then that's obviously too late, right? So solutions have to involve prevention, and that I think that's key. But I was sort of separate the solutions discussion into a question about, you know, there are a range of solutions and responses, and what works and what doesn't in your experience. Sheila, I will come back though, if don't worry. But then also later we could move into a discussion more explicitly on prevention. But it seems to me that these two things, they meld together, right? So feel free to discuss either of them. Really interesting statistic, Jillian, I had not heard that before, that 25% of overdose had been, right? It's seen a health professional in the past week. That's very interesting statistic. Yes. Sheila, sorry, I missed you before.
Shall I go ahead?
Oh, please. Yes.
Okay. I wanted to comment, not statistically, but anecdotally, to say that at Mom Stop the Harm, we do occasionally get folks who use drugs who ask us to write a letter for them to the hospital or to the physician, and we have done that. And I have myself written a letter with regards to a psychiatrist at CAMH in relation to someone in my family, where I felt personally that there was a level of negligence there around ignorance about what's actually involved in overdose. But in terms of the stigma, if you go into you know, like CanLI or a database and you look at Ontario human rights cases or other cases, I think the social benefits tribunals cases, you can see the way that people who overdose are spoken about. And in one case in particular, they talk about a young woman in London, Ontario, who had IV drug user on every page of her chart. You know, many folks use diabetics might inject, but that's not something that's kind of like a rubber stamp that says this person's different. And so I just want to give credit to people who use drugs who've been advocating for themselves, but just to state that more is needed.
Okay, thanks, Joanne. Just to note, Jillian has put a link to the report she mentioned in the chat, and I am following the chat comments. Thank you very much. We'll come back to some of them because some really interesting stuff there too. Sayida, you raised your hand?
Yes, I wanted to talk about what worked. So I think since federal government implemented the strategy, Canada Drug Strategy, involving all the 4 pillars, prevention, treatment, harm reduction, and enforcement, many of the interventions did work. For example, in prevention, naloxone distribution really made a difference. Outreach workers really connected the people with the treatment, although we need more on that. Treatment. In treatment, we provided opioid agonist therapy, including methadone, Suboxone, Acadian, which is new sort of in Ontario as compared to the West. BC, Alberta have been using it for quite some time, and IOTS, injectable opioid agonist therapy. Then in harm reduction, supervised consumption site, which I think is really evidence-based now. And I think there are 38 supervised consumption sites which have reversed 27,000 overdoses without a single death. So that is a remarkable achievement that speaks for itself. It's evidence and it's really work. And it has connected many people with the social services too. Now, what didn't work? Yes, opioid agonist therapies were available, but those were not equitable. People who were in rural areas, especially our Aboriginal population, like those opioid agonist programs were not accessible. Time, distance, geography, all those. Then the very stringent or very, very strict guidelines or treatment policies around that, like prescription monitoring, urine drug testing, and not allowing the take-home carry doses. Yes, in pandemic, we became more flexible, but before that, those policies were very stringent. And many people could not be retained in the program because of those stricter policies, or sometimes even the arbitrary threshold cutoff point of the methadone dosing, right? So I think those guidelines still need more work to be revised. Those should be based on people's need, and focus should be people suffering. So not an arbitrary guideline. So I think we need to do more work so that these opioid agonist treatments are available, like the access, and we should be more innovative now with more technology. And I think with more partnership, we can be more advanced in terms of implementing these therapies, the digital RAM, right away, or maybe putting up the satellite RAM clinics or mobile RAMs in the hotspot areas. Another good thing which I should give a due credit, data monitoring and surveillance, and good researchers like Jillian, like who have been gathering all the qualitative and also quantitative data, which really is informing our priorities and where to focus the intervention. But at the same time, I think we need more researchers to evaluate our actions so that we know the impacts, what has made the difference for the population health outcomes. So I just wanted to mention those.
Okay, that's quite a bit, but absolutely. And yeah, and program assessment, right? It's yeah, we don't talk about that enough. So I've lost track of who had their hand up first. I'll go with Serene first, then Beth, and then Jillian. Serene, you're on.
Sorry about that. You think you'd have this figured out a couple of years in. So I'm going to speak specifically to First Nation communities and the prenatal or pediatric context or population. The one thing I will start with is treatment centers that bring together mothers and children. So treatment centers that allow children to come with mothers is incredibly important and rare and challenging to get into. I mean, treatment centers, the access to them in themselves is a challenge, but then you have a vulnerable mother who has to make a choice between giving up her children, and a lot of mothers may not have somebody safe for those children to stay with. So it might mean signing over care to Child Protective Services. And particularly for Indigenous women, that is a very challenging thing to do given the historical and current context of the relationship with child services. So I think for a lot of moms, they're not willing to give up their children to go into treatment. And fair enough, in that situation, that's a real tough choice to ask a woman to make. I think another thing is that, and we've already heard this, is having better access to opioid agonist treatment, particularly for women who are pregnant or who maybe have young children. And then you live in a rural, remote community where you have to travel to a local city or the closest city to get your treatment. That's really tough. I can tell you stories from our qualitative work, but picture a mother in the middle of a Northern Ontario winter having to pack up her small children to go wait in a lineup outside because it is COVID and you can't have people inside the clinic for 2 hours in their snowsuits. And she's, with multiple young children, and through public transport, or if she's very fortunate, many communities do have medical transport for people. That's a lot to ask any mother, particularly somebody who's struggling with addiction. So I think we've seen improvements in carries, and there are certain situations in First Nation communities where that works really well, but just increasing that access. And then to also speak about opioid agonist therapy in pregnancy a little bit, there's a lot of misinformation around what happens with opioid agonist therapy to the mother, to the developing fetus, or to the baby, what happens in labor and delivery. And women often aren't given enough time to explain their options, explain what's going to happen, have those questions, and just a healthcare provider take time to sit with them, let alone an addiction specialist, to sit with them and walk through what this might look like when you give birth. So we hear women feeling like they're duped. They give birth. And so what often happens with opioid agonist therapy is that the baby has neonatal abstinence syndrome. So it's a withdrawal syndrome that can be managed very easily, but oftentimes it can, because of other health complexities, sometimes related to the opioid use and sometimes not, that baby may have to go into the NICU and be separated from the mother. They may have to be transferred to another hospital if it's rural or remote medicine, come into sick kids. So we see these mothers saying, I did what you told me to. I did what I was supposed to. I took the Suboxone, I took the methadone, and you still took my baby to a NICU, and I haven't seen them for 2 weeks. I haven't been able to have skin to skin. I haven't been able to breastfeed. And then we see spiraling happen. But then some women, we hear really good stories where somebody sat down and said, this is what's going to happen when baby is born. It's going to be really scary and hard, but it's a lot better than the risk of street drugs, which could probably most likely result in infant mortality or you passing yourself. So I think those conversations just aren't happening with pregnant women. And I'll go a little longer because if you don't mind, I've got a few other points and they all sort of weave together. For First Nations women, also we hear from a lot of them that their culture, the women who have come through and are now walking on a good, what we call a shaded path, their culture has been integral in their healing journey, just as we hear other people go through faith-based treatment. But it's that returning to community, to a sense of connection to your land. It's holistic, and we see a lot of really good treatment plans in First Nation communities where it's integrated with Western medicine. And there's a growing body of evidence that these cultural approaches to treating substance misuse are very, very helpful. And then I think on top of that, looking at addressing an intergenerational trauma in communities is at the forefront of addressing the addiction crisis in First Nation communities. It's getting at the root of the issue. It's addressing the intergenerational challenges associated with children being removed from their parents, not learning to be a good parent. I could go on forever, but intergenerational trauma is something that we desperately need to address. I'm going to let other folks go, but I'm going to, hopefully if there's time, circle back and I talked about what works for mom, but now I'd like to also come back to what works for baby and for that child as they grow and develop, because another issue with the opioid crisis is that often children born who have been exposed prenatally go on to have different challenges, sometimes early in their life, but also throughout their lifespan. So I'll hit the brakes for now. Thank you.
Okay, no, thank you. That's such a nice window, right, into another side of this. And it often strikes me that family addiction is a family problem, and yet we are taught more or less to treat it as a problem of the individual. And back to the stigma, the failed individual, right? And solutions have to be family oriented. And so that really hits home with what you just said. Beth?
Yeah, I just wanted to touch on a couple of other things that I think have worked as well. So one of them would be around, really trying to create low barrier access to services. So, really finding ways to meet people where they're at, to, be able to welcome somebody into a discussion about potential options for treatment as easily as we possibly can without, referrals and jumping through hoops and going here and going there, like finding really low barrier ways to create that access and capacity, I think is really important. I also think one of the things that has impressed me over the years incredibly about this community is the way that we've come together. This challenge that we're facing right now isn't something that any one organization, any one entity is going to be able to solve. It takes all of us coming together and saying, what do we contribute to trying to find solutions, to try and, create that capacity. So, there's a number of tables that have been active, probably more so prior to the pandemic, that need to be revitalized, specifically around this crisis. So, we have a great table that's come together that involves, public health, many different providers, the police, housing, the region. So I think it takes everybody coming together and really making a deep commitment to trying to advance this incredibly important work. So I think that's one of the things that's worked well in this community that we probably need to come back to and start to advance again. So I did want to mention that as well as to say, I think what works well is when we really take seriously a harm reduction approach. And take that very seriously and understanding what that means for individuals who need to access care, who need to have some freedom to make some choices, have dignity in making those choices. So I just would want to call that out. And if I could just make a wee mention, we talked about earlier, the things that why this hasn't received the attention that it needs. I think there's a really interesting call right now to action around moral determinants of health. And for those of you who aren't familiar with the concept, I would encourage you to do a bit of research into it. I think that, we talk a lot about social determinants, and I can tell you that, the pandemic has taken such an incredible toll on individuals in terms of affordable housing, in terms of food sustainability and, good food access. Like there's so many things that are contributing to this. And I would just want us to pause and consider what that moral calling would be and what those moral determinants of health would look like. And I'll stop there.
Okay, very interesting. Thank you. Jillian.
Thanks. So I'm going to talk about a couple things that don't work before I move into things that do work. The first thing that we know very clearly now that doesn't work is criminalizing people who use drugs. Unfortunately, when we talk about the four-pillar approach to addressing drug-related harms in our society, we've never actually invested very well in any of the pillars except for enforcement. Enforcement gets between 80 and 90% of all of our drug-related budgets, and it unfortunately has led to a lot of harms, putting people in jail, incarcerating people because of drug use or because of drug possession. Unfortunately, we know that this raises their risk of fatal overdose. We know that this creates numerous problems, and it doesn't actually lead to better health outcomes. I think it's been a failed policy, and we're starting to get some recognition of this. Even the Canadian Association of Chiefs of Police 2 years ago released a report acknowledging that criminalization was not working and calling for the decriminalization of drug use in Canada. And so I think that we have to acknowledge we've put a lot of our eggs in one basket, and that basket has actually been very actively harmful for people. And we've done it at a detriment to the other baskets that might have been more effective. I think the other thing that doesn't work is staying quiet about the impacts of racism and the colonial legacies within Canada on the problems that we're facing right now. And I really appreciate Serene bringing up some of these and some of her work within Indigenous communities, because I think that we need to recognize the ways in which there's ongoing impacts from residential schools, from the 60s scoop, and again, from continuing to use child and family services to intervene with families, particularly with Indigenous and Black families, and the ways that that has really detrimental impacts. We talk a lot about trauma, we talk a lot about prevention, but we need to acknowledge the ways that forced family separations around drug use actually create trauma among families, among parents, among their kids. And we really need to start privileging methods to support kids within their homes and within their families, and to provide active supports, to support family reunification rather than apprehensions. We really need to focus in on that. There's a lot of misconceptions about opioid agonist therapy within child and family service workers. I know a lot of women who are stable on opioid agonist therapy who have a CAS worker who doesn't agree with it. And therefore they get put into a really difficult position. And then doctors are called in to be having to advocate for the fact that this is in fact the gold standard treatment that they're using currently. And this is a very, very important point. The other thing that I think we have to acknowledge that isn't working is creating false dichotomies between the different responses to the overdose crisis. I'll often hear people trying to put treatment up against harm reduction as if they're somehow opposing approaches, when they're very much not. We very much need to have a comprehensive response to the overdose crisis right now, and pretending that somehow treatment is going to be the panacea to address this crisis is not going to be helpful. Treatment is completely necessary. We need low barrier, easy to access, evidence-based treatment for anybody who wants it on the day that they want it. But we have to also acknowledge that a lot of people aren't interested in treatment for different reasons. Either they've tried it before, it hasn't worked, they don't feel like it's there right now for them. Also, the fact that about a third of all people who we can find records of after they've died of an overdose-related death, a third of all people don't have any evidence of an opioid use disorder. And so addiction treatment is not going to help us with people who don't actually meet the criteria for opioid use disorder. People do use opioids recreationally, and people are dying of using opioids recreationally. And so we need to ensure that we're actually having a broad-based solution that addresses all the different people who are using drugs, not just those who are having the most problematic patterns of use. And I think that that part is particularly important, because if we think about the response to the overdose crisis as effectively a response to a tainted drug supply, anywhere else within public health where we have a tainted supply of something, for example, you have E. coli on lettuce. What do? We pull the E. coli lettuce off the shelves and we don't let people access it. And we ensure that we're giving people lettuce that doesn't have E. coli. Same with there was an issue with water or any other thing. Right now, our main issue is we have a tainted drug supply, but because it's an illicit, unregulated supply, we don't actually have a way to take it away. And so this is where I think trying to think about other options, like, for example, access to safe supply, to regulated forms of pharmaceuticals might be an option as well that might be very helpful in helping to address this across the board. Peter, I think you were the one who was muted still there.
Oh, I'm muted there. Sorry. I was telling Beth to mute hers. Yeah, I was asking politely if Beth, could you please mute, because we're picking up a lot of, okay. But yeah, this question of public communications is a really interesting one as well, right? In terms of how you communicate, for example, when we know, that there are street drugs in circulation that are killing people, how do you get that message out, right? And sometimes it's just left to the street, isn't it? Although I know that the police even play an active role sometimes in getting that message out. But thank you, Jillian. You raised so many fantastic points there. So I'll go to Sheila and then Winnie. Sheila, we're not. You're still on mute, Sheila.
Sorry. In terms of solutions, access to everybody, be you rural, northern, inner city, a complete spectrum of fully funded services and supports. And we can't focus only on opioid agonist treatment. It doesn't work for a number of people. They don't want to be on opioid agonist treatment. And so I think that we have to be careful that we're not being selective about who's going to be helped and who won't. And I was quite interested with Beth's term, moral determinants of health, because I actually hadn't heard that before. But it brought up for me this notion of moral distancing, which is what I personally believe is at the heart of people being able to turn away from the overdose situation. They judge it's morally distancing, and that wouldn't happen to me, and da 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 da. And so we often feel at Mom Stop the Harm, until it actually does happen to someone's family member, they're not going to get it. And I don't know how we jump over that hurdle. But also one final point, Jillian, about 3 years ago, I sent an email to the director of Metro Children's Aid to ask for their policy on opioids. And I was shocked. They don't have one, or they didn't at the time. And so definitely moms and others will be dealing with one worker at a time. Some will be enlightened and some will not. So that's all I had to say.
Do you mind if I just do a quick follow-up on that? I've done some research like Serene on the situation of moms who are either pregnant or parenting and using opioids. And I did a lot of work talking to frontline workers who are helping and supporting moms in that situation. And they said exactly that, Sheila, that so often they would actually do huge amounts of education work with children's aid workers, family services workers, about what the best treatments are. I know doctors who've done tons of work with an individual CAS worker around opioid agonist treatments, why they're the gold standard, why this is a medical treatment and should be continued. But it's not across the board. It's like happening on a very individual level. And given the way in which drug use is so pervasive within the child welfare system, and I really do think that there needs to be systematic training across the board, because this is really a major knowledge deficit. And it shouldn't be the case that if you have a worker who is well knowledgeable about things, you're able to access the best level of care. But if you have a worker who doesn't and is functioning on kind of like received beliefs about all drugs being bad and all the rest of it, then you're going to have a completely different and often negative experience. And so I think it's a really important point.
Okay, yeah, sure, absolutely. Standardization at some level. Winnie?
Yeah, so I just want to add to the panelist discussion about what works. And some of the work that I've done is about Nanoxam access. And we find that the Ontario Nanoxam program for pharmacies, it really worked because it's freely available without cost, without prescription for the program users. That really worked, and it really increased the access to naloxone. And that also the other thing that didn't work though is the stigma. Though stigma has to reduce related to the use of naloxone. It was identified as a major barrier to the use of naloxone. So there needs to be a public education about how naloxone saves lives, the injectable versus the inhalation naloxone. So it's the different forms of naloxone that could be available from the pharmacies, and that could be really really helpful for the public education about how to reduce the risk of naloxone and really help the public to reduce that stigma. So naloxone training education for the public and service providers is really important, that we find from the study. And the other thing that we find that was important is related to homelessness. So the City Studio Derm initiative that we did, we found that community hubs for homeless populations that were set up in the Durham region really worked, because these hubs really provide that wraparound services for homeless populations, mental health, addictions, health services, and it really provides that services through a single point of access. It's patient-centered, it's flexible, it really diverts that from the high cost of emergency services. It also diverts towards housing access. So the community hub models really have to continue to develop in order to improve that access for homeless populations towards getting that wraparound services and to improve their access to housing. And the other thing is to focus on is about the Ontario Naloxone program for the correctional facilities, because I think that is really underrated and not being used much. The problem is that a lot of the inmates, recently released inmates, they are really at high risk of having addiction and mental health issues. However, we find that from our study, the provincial correctional facilities take-home naloxone program is not really well advertised at this point in time. So that's another barrier. And I also wanted to mention about how women are also experiencing mental health impacts, particularly during the pandemic, and that the women particularly encounter additional stigma when accessing health services related to drug use and naloxone access as well. So we really have to look into that and think about ways to enhance this programming to support women to have that proactive outreach program to help these women to increase their social support, and also provision of harm reduction services to help tailor the needs of those women. And I wanted to also mention about the other population is older adults. Older adults, they are the ones who also experience high number of opioid-related deaths, and that among age 65 year and plus, that doubled during the pandemic. And that's mostly because of social isolation during the pandemic. And that is a major issue that we should look into. And that's why I was involved in that deprescribing network model, where I was involved in the Canadian Deprescribing Network to focus on advocating for deprescribing of inappropriate use of opioids and also other harmful medications, because we found that 1/3 of deaths, of opioid-related deaths, actually have some other harmful medications related, such as benzodiazepine. So there is that over-prescribing of opioids and also over-prescribing of sleeping pills among older adults for their depression, anxiety. So this is something that we have to look into. So I just wanted to point out that deprescribing is one way to focus on how we can educate the healthcare professionals about the problem with overprescribing of opioids And that seems to be working really well from my research.
Okay, thank you. Yeah, we haven't talked about the overprescribing debate, I'll put it that way, yet. So that's certainly part of the equation, I know, and especially obviously in the US as well as Canada. Saida.
Yeah, I just want to mention that we have seen opioid overdoses were fueled during the pandemic. Part of the reason many of the people who were employed, they lost their job and they couldn't afford the medication coverage. People who are already on Ontario Works, or disability, yes, they have medication coverage, but any other person who is not eligible for social assistance, they have to pay from their pocket. So they lost their employment or medication benefit and they were unable to afford it and fell off the treatment. So then they had to resort to the street opioid, and that caused to increased in the overdoses as well. Again, also I want to build up on what Vinny said, that there is a gap in the treatment services across the board, like people who are well maintained in the treatment here in community, but for one or other reason, if they are incarcerated, no readily available access to the treatment, right? And again, when they are, or they have to wait for a longer time in correctional services to get back on the treatment. And when they are released, no proper arrangement or liaison with the community clinics. And that puts them at high risk because all of a sudden they are on the street, they are homeless. And that's, I think, biggest gap in the services. So I think we have to look into those solutions as well, how we can fill in the gap.
Thank you. I think that there's a lot of populations that we're mentioning here that most of us don't think about on a daily basis. So it's wonderful to hear this. Saray?
Thank you. So I'm going to switch back to children, but I did want to mention what a few people, Jillian and Winnie and others, have said about training and education. In all of the First Nation communities we work with, this is the #1 request, what they want. They want training on every aspect of opioid use and treatment that they can get their hands on, and they're struggling to get it. And they're calling for it, like from individual families to a high level, like chief and council, similar to what we're sort of these conversations we're having today with inviting members of local government. Service providers, teachers want it very much so, and I'll tell you why in a moment. And then wraparound services are so crucial when you need to engage the entire family unit. And so I'll use that to sort of slide into children. So just to make sure that we're all on the same page, there can be short and long-term difficulties for children who have been exposed to opioids prenatally. This can include anything from prematurity. You're more likely to go into labor early if you are using opioids. And then there's a whole host of pediatric issues that can come with prematurity, lung development, and things like that. But then we also see behavioral issues. We see speech and language challenges. Those are quite high, and we're already seeing speech and language challenges increasing in the general population. Fine and gross motor development, and then vision issues are very common as well. Some of these challenges, it's very tricky. They arise shortly after birth, and others increasingly noticeable as children grow, and some children will have no issues whatsoever. And what's very difficult in looking at the data is whether we can deduce if the long-term outcomes are due to purely opioid exposure or to environmental and social risks that accompany often the child's life when they are in a home where there are opioids or other complex social issues. We also have to take into consider other aspects of poor maternal health, high levels of stress during pregnancy, poor levels of maternal nutrition, and all these things we know can have an impact on children's development. So a child's development starts long before a mother even conceives a child, and that's when we look at when babies, about the lifespan now. So when we look at the solutions in what works, I can say that I think supporting the family unit is most important. Family preservation, where possible, is very important. Keeping families together, they are stronger together. Now, that's not always an option, and we all know that in this group here. But if we can keep families together, there are really excellent parenting interventions out there for families impacted by opioids specifically, but also other substance use. And there's parenting programs that help parents develop the competencies to be good parents, for lack of better words, to address some of the challenges that their children might be having in a behavioral capacity, and just an integrated care model where parents are learning parenting skills, but they're also their addiction is being treated, the family's involved at certain levels. So it's that wraparound aspect where we're caring for the child, but also the parent, because we're looking at them really as a mother-baby dyad, as one unit, as much as we can. We also need to see increases in standardized developmental screenings for children exposed to opioids. And this needs to go right through childhood, but often there are challenges in getting children to see a healthcare professional. And a lot of that is centered on something that the theme of today, which seems to be stigma. We talk to mothers, and day in and day out, they live in, and if they are living in a good way now and that they are not using opioids, there is a constant fear every single day of their life that something will come up next time they take their child to the doctor. And we have mothers who their child might have a knee issue, and they are sitting there telling us that it might be because of the opioids. And even though a healthcare professional has told them it's not, it is this horrible guilt that accompanies them. And then we also then combine that with the stigma and the shame that can come with going to see a healthcare provider. And sometimes that prevents women and families from taking their children in. But we know that we need increased screening so that if issues do arise, we can help children. There are really great children's development centers across our province, and they're doing excellent things with families and helping children with anything from gross motor delay to speech pathology. But unless we know that there's a challenge, we can't help that family. And I think that's one of the biggest things. So I think those are some strategies in helping children. And I say that in what's working, but also a note to prevention, in that we know that addiction is an intergenerational and family issue. And that number one thing that mothers will tell us is that their biggest fear, in addition to these health issues, is their child will walk down the same path that they did. So they are busting their asses every single day to stop that cycle, to break it, and to be the mother and that they want to be. And it's incredibly inspiring to see. But we do have a few things that we can do to help these mother-baby dyads be at their best. Thanks.
Okay, absolutely. Thank you. So Julian, maybe I know you had your hand up for a while, so if you wanted to say something, keep it as short as you can. But and then I'd like to go around just one more time and ask everyone to think about just very briefly, because we are running out of time. But if you could tell us, if you had one thing you'd really like to see people pick up on, whether it's city officials or provincial or what have you, federal, you name it, or universities even. I was thinking myself, universities could play a more active role in the communications aspects here and various things. So if you had just one thing, maybe you could tell us what it would be. But Julian, if you had something else to add first, we could go there.
Well, maybe I'll do the 2 in 1, and I'll try to wrap them together. So I think one of the things that I wanted to call attention to was how oftentimes when we're talking about the overdose crisis and opioids, we need to make sure that we're using the appropriate level of nuance to talk about these issues. So for example, when we're talking about deprescribing, I think that the overprescribing of opioids was very, very, a huge focus was put on that around about 2010, 2011. Since then, we've actually dramatically deprescribed in both Canada and the US. In Ontario, the prescribing of long-acting opioids declined by 23% between 2012 and 2016. There's been a 22% reduction in the number of the annual rate of people receiving long-acting opioid prescriptions in that same period. I think the important thing is is that for people who are on a long-term opioid prescription, particularly people experiencing chronic pain or other conditions, deprescribing can be very, very difficult. For people who might be using opioids in a way that might be causing problems, deprescribing can be deadly, because we know that when people are rapidly deprescribed, they frequently have recourse to the illicit unregulated market, which puts them at a markedly higher risk of fentanyl overdoses. Now, do we need a different approach for those groups of people than for people who are getting a very first opioid prescription? Yes, very much. I think that we know now that we need to be much more cautious around first opioid prescriptions and around how those are used. But I actually worry quite significantly that we're moving into an era where we're going to dramatically undertreat pain, both acute pain within hospital settings, as well as people who have long-term chronic conditions. And I think that we have to have a little bit of nuance in figuring out how to walk together with people who are receiving long-term opioid prescriptions. Because ironically, I also think that increasing access to pharmaceutical opioids for people who are dependent on street fentanyl is an important measure to take. When you're taking a drug of unknown potency and that is a very volatile street drug supply, I do think that it is safer if people are moved onto a pharmaceutical alternative of a known dose and composition. This is frequently referred to as safer supply. There's some small pilot programs happening. But I think that we need to think through carefully which groups might actually benefit from access to opioids and in which groups we need to be much more cautious around opioids. In terms of the concrete steps that we might take, I think that, and this comes back to something Serene was just saying as well, I think we can't divorce the policy responses from the overdose crisis with the larger social context at the moment. We've seen in the last 5 years an intersection of the overdose crisis and affordable housing crisis, the COVID pandemic in the last 2 years, but also we're in the middle of 30 years of austerity budgets where our social services in general have been dramatically cut. The amount of money that people who rely on social benefits is so low that it's literally impossible pretty much anywhere in the province right now to receive social assistance and also be able to afford a market rent on an apartment. People don't have access. They're living in such extreme poverty that they don't have access to nutritious food. They can't have access to good housing. We've seen an 139% increase in deaths, overdose deaths among people experiencing homelessness during the pandemic. I mean, I think that really we're seeing this crisis of the neglect of our social programs and the neglect of strong investments in our social services and in kind of like that social safety net that we had for so long. We're really seeing that come to bear at the moment. And I think that we really need to think through how we can bolster the supports we're offering within communities for people who are most in need of them, because that's become a little bit of something that we're not supposed to talk about anymore, but I think we need to go back and start talking about it again. We need to be able to build healthy communities. That might mean that we need basic income for everybody, affordable housing for everybody. And I think that those measures are going to be just as crucial as, for example, expansion of harm reduction supports, supervised injection sites, or safer supply. We really need to be dealing with those together at the same time.
Thanks, Jillian. Big picture stuff, yes. Sahida.
Yeah, okay. I wanted to say that this opioid crisis is complex, multifaceted, and it actually requires a coordinated response from all levels of government and multi-sectoral, not only health sector, but education, social services, criminal justice system. And so that our like politicians or policymakers, they should build healthy public policies focusing on the prevention, investing more on youth programs, high-risk youth programs, parental programs, maybe guaranteed basic income, investing money on the home, affordable housing, all those things to fix the social determinants which are grossly linked with these opioid related deaths, and expansion of all the treatments, including methadone, Suboxone, Estrom, and supervised consumption sites, as well as safer supply. And whatever services are available, they should be wraparound services, a comprehensive care where physicians are comfortable to even do social prescribing, giving prescription to the gym for the swimming pool, to help out with the food insecurity, stuff like that. So that should, and in all this, we have to involve the people with lived experience and the families who have been affected. So those are on the table, and those interventions are based on the need of the community. That will give us a true perspective what we need to do. Thank you.
Thank you. Winnie, concluding thoughts?
Yes, I just want to appreciate Jillian's previous comment about the prescribing. And I just wanted to just make a very quick comment about that. And there's a lot of misconception about the prescribing and in terms of what it means. So I just wanted to mention that de-prescribing is really about finding a better alternative. So both drug therapy and non-drug therapies. And that is very important concept that we want the public to learn about, and also the healthcare providers to learn about. So raising awareness about finding a better alternatives. So both drug therapies and non-drug therapies. And another thing that I wanted to mention, in terms of the important things that I wanted to conclude is because of the research work that I'm doing with homeless population. So it's important that with the homelessness, that it needs to plan and implement strategies to ensure that there is a health-informed response to opioid crisis and homelessness in Durham region. And there needs to have a community medicine model of support, embedding mental health and addiction support in homeless program, and focusing on creating supportive housing model, identifying resources that will address the needs of those who are vulnerable of homelessness across the Durham and other regions, and to ensure existing regional funding opportunities that are maximized. So the priority is on engagement, shared care planning, information sharing between healthcare providers, that's collaborative approaches to mental health addiction. And that needs to strengthen that partnerships and communications between addiction service providers, psychiatry, and primary care to support this vulnerable population.
Okay, thank you. Beth, concluding thoughts.
Yeah, I won't reiterate what my peers have talked about. I agree with everything that's been said, but I guess my one wish would be that, that we keep this conversation alive, and that we keep this conversation going, and that we find ways, to start to educate ourselves, our children, our, communities on how to have these conversations safely, how to make sure they're based in compassion and understanding and education, and that we bring into those conversations as well, the mental health dialogue, because I think you have to bring, I'm so glad Winnie mentioned that. I think we have to bring the two things together. They can't stand in isolation, and we have to address them together, and we have to have those conversations together. And I think the other piece would be around, really making sure, particularly our healthcare providers and others are starting to understand what trauma-informed care really means, and start to bring those conversations forward. I think it's sometimes something that we just toss around, and can be very life-changing if we can start to have those conversations at a much earlier stage. Stop there. Thank you.
Thank you. And you stole my concluding comment. Let's keep talking. Absolutely. This is just a great beginning, but Sheila and then Serene, and then we'll have to end it.
Okay, I'll just make it short then. I noticed yesterday that the Winnipeg city councillors had commented that they're going to be asking the federal government for decriminalization, and that the Vancouver mayor had similarly made a call for that 3 or 4 years ago. And in Toronto, Eileen Davila has asked for decriminalization in Toronto. And so my feeling is that there are pockets across Canada. There are some municipal pockets, some provincial pockets, occasional, federal government popping its head up, but we need a roundtable that includes all pockets and all different groups. First Nations group, Esther's Tail Feathers has been very active in that area. But not everybody is talking to everybody else, and that's a problem. I do want to talk about the right to housing, but there isn't time, so I'll leave it at that.
Okay, thank you. But it's a wonderful idea, Sheila, to move. That's a role the university can play. You know, we try and do that in terms of bringing different people to a table, right? So definitely, you haven't heard the end of this from me. I can assure you of that. Serene, any concluding thoughts?
I echo what everybody has said. My last sort of thought that hasn't, and it's been sort of touched on, is that, and Peter, you had mentioned, universities, I think, can do have a larger role in knowledge translation and communication in this crisis, particularly at a community level. But that also requires an investment by universities to ensure that those type of actions are reflected and valued at the same level of other types of productivity. And that's something for universities that they need to focus on in order to reward that type of work and allow us to do that. So that's it.
Okay, thank you so much. We've run a bit over time, and I apologize, but thanks to the audience. I hope people have been looking at the chat because there's some really interesting things in there that we haven't had time to address. But as I said, I hope we can continue this dialogue. And fantastic panel, so many important ideas, and given the seriousness of this topic, I was really pleased with the level of sophisticated discussion. And I also wanted to thank Karen Douglas, who's here, who helped coordinate this event today. So thanks very much, everyone, and we'll be in touch and stay safe. Thank you.
Thank you. Bye.